process that our kidney filter the excess fluid and the waste products out of the blood. So from the glomerulus pergi ke Bowman's capsule and go to the tubule, go to the collecting duct and excreted as our urine. So the fluid that is filtered out, we call it ultrafiltrate. So this ultrafiltrate contains the water and all the small solutes, but not proteins and blood cells. So what is glomerular filtration rate? Is the volume of plasma that is filtered by the glomeruli per unit of time. So in a normal person, our renal plasma flow is around 20% of the cardiac output. So renal plasma flow usually is around 6 to 5 mils per minute. So from these 6 to 5 mils, they go from the afferent arteriole, go to the glomerulus, and after that ultrafiltrate become our glomerular filtration rate, which is around 1 to 5 mils. So if you see from here, our 1 to 5 mils glomerular filtration rate is actually 20% of our renal plasma flow. So here we have our equation, filtration fraction is equals to glomerular filtration rate divided by renal plasma flow. So in a normal situation, our filtration fraction will be 20%. So from this 1 to 5 mils, 99% will be reabsorbed back into the blood. So only 1% will be excreted as our urine. So like just now what I mentioned, we only filter fluids and small solutes because thanks to our glomerular filtration barrier lah. So here we see, we have, if we zoom in up here, we have 3 layers. The first layer is our endothelium. Second layer will be our glomerular basement membrane.
Hello Tio. Suara tak ada Tio.
We have 3 barriers. Okay, so if we zoom in out here, we have the 3 layers lah, the endothelium, glomerular basement membrane, and also the podocytes. So the endothelium, we have the fenestra of around 70 to 100 nanometer. So the fluids, solutes, and the plasma proteins, they can filter, but not blood cells, because the blood cells is larger than this size lah. Then the second membrane we have is our glomerular basement membrane. They are negative charge. So means that the solids that are negative charge, like the plasma proteins, that also cannot be filtered from this layer. Then the third layer, we have our podocytes. They have in between them, they have filtration slit, which is around 25 to 60 nanometer, and they are negative charge too. So means that the plasma protein also cannot be filtered from this layer. So from here, we can see that only the fluids and the solids can be filtered, but not the blood cells and the protein, because due to their size and also the charge. Okay, so now we can see the filterability of the solutes actually depends on our size and also the charge of the solutes. So obviously the smaller the size, the better the filterability. So the molecular weight cutoff for our filtration is actually less than 70,000. So anything less than 70,000, actually they can be filtered. So if you see here, our water, sodium, glucose, and inulin, they have filterability of around 1, means that they filter as freely as the water 100%. And the myoglobin, they have 0.75 of the filterability, means that they have only 75% as rapidly as the water. What happened to albumin? So albumin actually is molecular weight is around 69,000. So actually they have bit in the range less than 70,000, but then their filterability approaching to 0 because albumin is a negative charge. So obviously they will repel from our basement membrane. So the filterability of solutes is inversely proportional to their size. So the second factors, the negative charge solutes filter less easily than the positive charge. So if you see this graph, anything that less than 7 nanometer, actually they can be filtered, but depends on the charge too. So the cation, which is the positive charge, will be more filterable. followed by neutral, and followed by the negative charge. Because our filterability, because our glomerular basement membrane, they have negative charge, so they repel the negative charge solutes. So in some certain kidney disease, they have loss of the negative charge on the basement membrane. So they cause the albumin to be filtered, so they can cause proteinuria. Okay, here we come our equation. Glomerular filtration rate equals to filtration coefficient times net filtration pressure. So any decrease in the filtration coefficient or decrease in the net filtration pressure will decrease our glomerular filtration rate. So we see one by one. So we learn the net filtration pressure first. So before we move in this, we have to understand what is Starling pressure or Starling forces. So this is the pressure that drives the fluid movement across the glomerular capillary membrane. So as we learn from our physiology, we have two types of pressure, hydrostatic pressure and oncotic pressure. So for the hydrostatic pressure, it is the pressure exerted by a fluid at rest due to the force of gravity. So it is like a force of pushing. If we have our glomerular hydrostatic pressure, means that it's the force of pushing of the fluid from glomerulus into the Bowman's capsule. And remember, hydrostatic pressure, we use a label as P. So the second, we have oncotic pressure. So the oncotic pressure is the osmotic pressure generated by our proteins. It's like absorbed by our proteins. It's like a sponge. So it is the force of pulling. So if we have our glomerular oncotic pressure, means that it is the force of pulling of the fluid from the Bowman's capsule into the glomerulus. Oncotic pressure, remember, we label it as pi. Okay, so in every space, in the glomerular space, in the Bowman's capsule space, in every space, they have their each hydrostatic and oncotic pressure. So here, before we move in, we learn about the label first. So like just now what I mentioned, the P means that hydrostatic pressure. G is the glomerular. So this is glomerular hydrostatic pressure. This is hydrostatic pressure of Bowman's capsule. This is oncotic pressure of glomerulus. Okay, so the first we see glomerular hydrostatic pressure. So this is the force of pushing the fluid from the glomerulus into the Bowman's capsule. So glomerular hydrostatic pressure is the force favoring filtration, which is around 60 millimeter mercury. And the second one, we have glomerular oncotic pressure. This is the force of pulling of the fluid from the Bowman's capsule into the glomerulus. So this is one of our force opposing filtration, which is around 32 millimeter mercury. And the third, we have Bowman's capsule hydrostatic pressure, means that it's the force pushing of the fluid from the Bowman's capsule into the glomerulus. So this is also another type of the force opposing filtration, which is around 18 millimeter mercury. So here you see in the diagram, actually absent of the Bowman's capsule oncotic pressure, because our Bowman's capsule oncotic pressure is equals to 0, because obviously the plasma protein cannot pass through this, cannot be filtered. So will be 0 plasma protein in Bowman's capsule. So we have 0 Bowman's capsule oncotic pressure. So from the net filtration pressure is force favoring filtration minus the force opposing filtration. So means that is our glomerular hydrostatic pressure 60 minus Bowman's capsule hydrostatic pressure 18 and minus glomerular oncotic pressure 32. So here we get a net filtration pressure of positive 10 milliliter mercury. So if we substitute the equation come here, we'll get this lah. So now we learned already what is net filtration pressure. So now we see how the alteration of the pressure will affect our glomerular filtration rate. So what is the factors decrease glomerular filtration rate? Either you decrease the force favoring filtration, means that you decrease the glomerular hydrostatic pressure, or you increase the force opposing filtration, means that we either increase of the Bowman's capsule hydrostatic pressure or increase glomerular oncotic pressure. So here we see one by one. What is the causes causing decreased glomerular hydrostatic pressure? We have 3 causes. The first can be reduced arterial pressure. So obviously, when we have reduced arterial pressure, will be less plasma flow into the glomerulus, will be less generation of the glomerular hydrostatic pressure. But remember that arterial pressure, actually, they have only very small effect on the glomerular filtration rate because we have our autoregulation, which already explained by Dr. Lim Ka-shun in the first lecture, which is our myogenic autoregulation and also the tubular glomerular feedback. So actually, the arterial pressure has only minimal change on the glomerular filtration rate. So the second causes of decreased glomerular hydrostatic pressure is by vasoconstriction of the afferent arteriole. So when you, same also, when you vasoconstrict it, there will be less blood flow inside the glomerulus, less glomerular hydrostatic pressure. So this will happen when we have increased sympathetic activity or presence of some vasopressor, example, norepinephrine and also endothelin. And the third causes can be due to vasodilation of the efferent arteriole. So when you vasodilation of the efferent arteriole, will be obviously more blood flow out of the glomerulus, so we also decrease the glomerular hydrostatic pressure. So this will happen when we have reduced angiotensin II, because obviously the angiotensin II is the vasoconstriction for the efferent arteriole. So this will occur when we use some drugs, example ACE inhibitor or ARB. So now we understand already, decrease glomerular hydrostatic pressure, decrease the force favoring filtration, so they decrease glomerular filtration rate. The second cause can be due to increased force opposing filtration. Example, increase our Bowman's capsule hydrostatic pressure. So this will happen when we have urinary tract obstruction. Example, kidney stones. So when you have urinary tract obstruction, the urine cannot flow from the kidney into the bladder. So it means that the urine will be back up in the kidney, the backup in the tubule, and then the backup in the Bowman's capsule. So it will cause increased Bowman's capsule hydrostatic pressure, this which is a force of opposing filtration. So this will decrease glomerular filtration rate. And the third one will be due to increased glomerular oncotic pressure. Obviously, it can be caused by increased plasma proteins, because the plasma proteins is the force is used to generate the oncotic pressure. And also, second cause can be due to reduced renal blood flow. So here I have a diagram showing how reduced renal blood flow can increase our glomerular oncotic pressure. So as you remember here, the filtration fraction is equals to glomerular filtration rate divided by the renal plasma flow. So when you have reduced renal plasma flow, you have increase in the filtration fraction because you have more time to be filtered. So when you have increase in the filtration fraction, this will cause the plasma proteins that are not filtered will become more concentrated. So this will causing rapid rise in the glomerular oncotic pressure. So glomerular oncotic pressure is a force opposing filtration, so it will cause decreased GFR. Okay, now we understand already net filtration pressure. So the second factors that can affect our glomerular filtration rate is filtration coefficient. So this is very easy, only affected by two things, which is our permeability and also filtration area of the glomerular capillary membrane. So permeability is like what I said before, affected by the size and molecular charge. So the smaller the size, the higher permeability. The positive the charge, the higher permeability. And the second one, of course, filtration area higher, there will be higher filtration coefficient. So these are the causes, renal disease, DM, hypertension, they can cause reduced filtration coefficient and causing reduced GFR. So why is this so? Because in this disease, they have increased the thickness of the glomerular capillary membrane, which can decrease the permeability. And also they have the decreased number of functioning glomerular capillaries, which will decrease our filtration area. So permeability, we understand already, it depends on the size and the molecular charge. So what about filtration area? How they affect? So filtration area actually is controlled by our mesangial cells contraction or relaxation. So in our glomerulus, in between our glomerulus, we have mesangial cells. So mesangial cells is a type of modified smooth muscle cells that can contract and also relax. So when the mesangial cells contract, some of the glomerular capillaries will close. So the surface area will decrease, the filtration coefficient will decrease, and glomerular filtration rate will decrease. So these are some of the hormones that can cause contraction mesangial cells, which in turn decrease in GFR. Example, our endothelin, angiotensin II, ADH, and so on. And these are the causes that can cause relaxation of the mesangial cells, which in turn will increase the filtration coefficient and increase in glomerular filtration rate. Example, ANP, dopamine, and PGE2 and cyclic AMP. So remember that anything either decrease filtration coefficient or decrease in the net filtration pressure will decrease in our glomerular filtration rate. So this is my references. So that's all for my presentation. Thank you. Is there any question?
Okay, okay, thank you, Theo. Okay, we'll keep the questions later at the end of the session.
Okay.
Okay, now we're going to proceed with the next presentation. It's going to be presented by Dr. Dr. Jeannie, and the topic will be bicarb generation. Okay, Jeannie, the mic is yours.
Boleh nampak screen tu dengan saya?
Okay, dengar loud and clear, and slide boleh nampak. Thank you.
Okay, good. Good morning, everyone. Okay, I'm Jeannie. Okay, today we will speak about bicarb generation. This is a very, very, very small topic, and also very short and simple and sweet. So everyone can have a coffee, then bolehlah faham. Okay, so bicarb generation ni actually falls under the topic of acid-base balance. Okay, then why is it so important that we need to discuss separately regarding the bicarb generation? Because bicarb ni dia plays a very important role to maintain the normal acid-base balance in our body, and also I think is the major one lah. Kita ada banyak lagi, but bicarb is the major one that we discussed lah. And then also, why is this acid-base balance is so important? Because you need to understand that almost all of our enzyme in our body is influenced by the acidity lah. H plus ni means acid lah. So what acid? How it affects our body? Okay, so meaning that here, when your body is a more acidic environment, usually it doesn't favors our body punya normal physiological function. So all our cell and our body function will be affected. All the biological structure components, semua dia punya signal semua akan affected, and also our uptake and release of oxygen also will be affected. That's why this basically we are saying that if the acid-base balance is impaired, all our body function will be impaired. Okay, that's why this is how important it is lah. Okay, so let's see here. Okay, so how to maintain a normal blood pH? Okay, we have 3 systems in our body. Our body is always smarter than we think lah. Okay. So the first system is the buffer system, which this one is another big topic lah. I will just touch on the bicarb buffer. Okay, and the respiratory system. This one is the one that usually we understand lah. Patient datang, DKA, severe metabolic acidosis, tapi dia takip ni. This one is the mechanism lah that we always see in our DKA presentation. And also our main topic will be the renal mechanism. It's our third line lah. So I will just brief a little bit first why the renal mechanism is so interesting and is under the bicarb regeneration. Okay, so you can see from my slide, renal mechanism ni got 2 things. Okay, it can resorption of the bicarb. This one is involved in our bicarb and PCO2 buffer system. 99% of the bicarb is resolved lah, because as I said, bicarb is very important. And then this one also already discussed lah previously. Okay, so I won't go deep into this. And also the accretion of the acid, our hydrogen ion. Okay, so how it excrete? Okay, two ways. The one is it acid as a titratable acid. Later we further elaborate about it. And also it excrete as the ammonium ion. Okay, why these 2 is particularly important in the system? Because when we excrete these 2, it is accompanied by a new bicarb formation. Okay, this is my main topic lah, the new bicarb formation. Okay, so let's go into it. Okay, so first I touch a bit of the bicarb PCO2 punya buffer system. This one is buffer system. This one have no involvement in any bicarbonate generation. Okay, so as I mentioned just now, 99% of the bicarb is resolved from the proximal convoluted tubule. Only very little small quantity is resolved in other places. So meaning you can say it's 99.9999% is resolved. Okay, so how does this happen? Okay, so your body, when your body is working, is constantly produce acid lah. We call it like macam byproduct. Okay, so your body is very smart. So you want to excrete the body punya acid to maintain the normal physiological environment for your body to be function. Okay, so you see here. Okay, you have a very smart enzyme named carbonic anhydrase, and your body, everywhere of your body, we have carbon dioxide and water. Okay, anywhere lah. Okay, so this one we discuss is in proximal tubule. Okay, so this carbon dioxide and water, they are good friends. They found this very smart carbonic anhydrase. It will form this H2CO3, and then it will further break down into your hydrogen ion and your bicarb. Okay, and then Okay, so here is your blood, here is your kidney punya lumen lah, okay? So here, when your bicarb is formed, it will exchange with sodium to excrete, okay? To excrete out, okay? When it excrete out, it will cari bicarb kat luar yang filtered lah, yang filtered early on, okay? It will combine together and form back this H2CO3. And then another good friend at outside, carbonic anhydrase, it will break down balik, become a CO2 and H2O. These two is freely, readily can pass through the membrane, go back into the proximal tubule, and then this cycle will repeat and repeat and repeat and repeat endlessly, okay, to maintain your physiological normal pH. Okay, this is an endless loop. It will just continue, sampai continue lah. Okay, so this one is the resorption, just a quick view lah. Okay, so next, our main topic is here. Okay, so just now we said that we need to excrete the hydrogen ion card. So this is one of the pathway. This one is our phosphate buffer system. Okay, so how is it happen? So this happen in the distal convoluted tubule in our alpha intercalated cell. Okay, so it's the same thing. Just now I said we have a PCO2, our CO2, carbon dioxide, and water. Okay, they have a good friend, same good friend lah, carbonic anhydrase. Okay, they form this H2CO3, and later on it will further break down to your hydrogen ion and bicarb. It's the same. Okay, this whole process is the same. Okay, but what is the difference here is this hydrogen ion, it will be excreted either by the active transport of ATP ataupun by the changes of hydrogen with potassium come in. So they buang satu hydrogen keluar, absorb one, potassium come in. Okay, so what they meet outside, just now they meet again bicarb yang filtered outside kan. But now this one, because we are discussing about phosphate buffer system, so this one today, this bicarb, this hydrogen ion meet another new friend named phosphate. Okay, so what does it mean by, just now we noticed the term, right? The titratable acid. So what does it mean? So when this new friend, this hydrogen ion meet this new friend, they form this H2PO4, which is a weaker acid. Why I mention this weaker acid? Okay, because when your acid is too strong, it's very difficult for you to excrete. So your body will be very smart. It will try to lower down the acidity so that it can be easily excreted. Okay, so when this hydrogen ion meet this phosphate combine together, it will form a weak acid which you can excrete. Okay, so why is this system so important? Okay, so you look back the whole system, the whole chain from carbon dioxide to water to this H2CO3, suddenly pop, other bicarb. Okay, tapi you see here, the whole chain here, hydrogen ion, phosphate, H2PO4, here have no bicarb. So what does it mean? What does this diagram tell you? It's telling you that this pathway actually generating one new bicarb. Okay, new bicarb is reabsorbed. Okay, you have no bicarb here. Okay, we look back the previous diagram. Okay, see, we have our bicarb here, and we have our filtered punya bicarb. Okay, this cycle it repeats. You can understand that this bicarb is actually turn into this H2CO3 and it break down to another form, transfer back into the cell. So this bicarb is actually this bicarb. There is no net generation of bicarb. Okay, but this one, you see, no bicarb at all at here. But suddenly, pop, satu bicarb keluar. So this bicarb is the bicarb that generated, okay, it's newly generated from our system and we reabsorb it. Okay, this one is. Okay, so next we see another system. Okay, so this one is we excrete the hydrogen ions as our ammonium ion NH4 minus. Okay, so how this happen? Okay, so first in your proximal tubule. Okay, this one don't see first. You see here first. Okay, in our proximal tubule we have this glutamine. Glutamine ni is our amino acid lah. Usually what we makan, or meat, protein ke apa-apa, we have our glutamine. Okay, so how this glutamine is activated? Okay, glutamine in our cell ni, dia akan auto breakdown by one enzyme. I don't know what's the name of the enzyme, but how is it breakdown? Is by the acidic environment. Okay, later we say why is it so important. So when your cell ni, it detects an acidic environment. Okay, so it start to activate the glutamine punya enzyme. So glutamine punya enzyme ni, dia akan break down glutamine to ammonia NH3, which is a gas, or an alpha ketoglutarate. Okay, so this alpha ketoglutarate, there ada several mechanism lah, but eventually what is important is it will form a bicarb. Okay, so you see here, don't have bicarb, suddenly break, pop, new bicarb. Okay, so this is one new bicarb. Okay, so what happened to the next pathway, the other pathway? Okay, so there is two pathways. So one is, as we said just now, excretion of hydrogen as ammonium ion. So it need to combine with one more hydrogen ion in the cell, and it transfer, meaning it excrete out of the cell. Okay, excrete as ammonium ion. Okay, this is what our pathway is about lah. Okay, with the exchange of the sodium ion inside. Okay, so this is one pathway. So this, okay, I repeat glutamine, they break down, become ammonia. Ammonia ni they combine with a hydrogen ion, jadi ammonium ion, and excreted. Okay. So this ammonia gas ni, because it's a gas, is readily, it like to go where also can. Okay. So this gas suddenly you don't want to combine with your hydrogen ion here. You say, I want to go have a vacation. I want to go to holiday. So dia pergilah holiday sampai our collecting duct. Okay. This ammonium is actually this ammonium. Okay. They are the same person. Okay. Nampak apa tu tempat beza je. Tapi this ammonium is actually this ammonium. It's the same thing. Okay. So how he play its role here. Okay. Same. We go back to our intercalated cell in our collecting duct. Okay. It's the same. We have our carbon dioxide, we have our water, is readily available anywhere in our body. Okay, same pathway, it meets the good friend, carbonic anhydrase. Jadi H2CO3. This H2CO3 will further break down to H plus and bicarb. Okay, then again we got hydrogen ion, we need to excrete. Okay, so it's either excrete by an active transport of ATP or active transport of ATP in exchange of your potassium. Okay, so now you already have your hydrogen ion outside, excreted lah. Okay, same I say, hydrogen ion itself is a very strong acid ion. You need to combine, jadi weak, so it will combine with the ammonia gas outside. Okay, it's actually the same, nampak tak? But this one happened in the cell and this one happened outside the cell. It's just by your ammonia gas yang pergi vacation. Okay. So it will become another, the same thing, ammonium ion, and it will be excreted. Okay, so this is the excretion, but the excretion have generate your bicarb. Okay, this is what we are discussing now. Okay, so why is this system so important? Okay, two things. Because one, you can see from this diagram, by this pathway, hydrogen excretion as ammonium ion, it produce two bicarb. Okay. Canggih sangat, they produce two bicarb terus. Also, it is very reliable. Why is it reliable? Because this hydrogen as titratable acid, this one bicarbonate regeneration, it just carry on. Okay, it just carry on. It just repeat. But you know that this ammonium ion, hydrogen excretion as ammonium ion is very reliable by the acid-based environment. Because why? Because I just mentioned that glutamine is breakdown by the enzyme which is activated during the acidic environment. So only you detect acidic environment, your enzyme will be activated and start all this pathway, okay, to compensate by generating new bicarb. Okay, so this one is very reliable and more sensitive. Okay, and also lah, because we generate two bicarb, right? One pathway but generate two bicarb, efficient lah. Okay. Understand? I think this is all my topic lah about bicarb generation. Short, simple, and sweet. This is my reference. Okay. Macam ni lah. Thank you.
Okay, thank you, Ginny. Okay. For your information, kalau yang tadi apa yang Ginny cakap yang last kali itu kan, yang bicarb generation tu, that's a process what they call as ammonia genesis. So they produces ammonia And from ammonia generation, badan kita punya kidney will produce one molecule of ammonia will produce 2 molecules of bicarb. Right? So macam tu kita tengok daripada pertama sekali bila seseorang tu dapat acidosis, our first line defense mechanism untuk combat acidosis adalah kita punya buffer system. Dan kita punya bicarb, kita punya phosphate, kita punya albumin, proteins, kan? Okay. So tu adalah the first line. Second line, first line ni memang automatic lah, memang cepat. Memang bila orang ada acidosis, badan kita tu, kita punya buffer system akan bekerja serta-merta. Kan? So that's our first line defense mechanism against acidosis. Then second would be respiratory system. I think this will be controlled by our central and peripheral respiratory system, sama ada in the brain ataupun kita punya central in the brain, and peripheral adalah dekat kita punya carotid dengan aortic body. Okay. So ini akan happen dalam masa 24 jam hingga 72 jam. Kan? So selepas seorang tu ada acidosis, kan, dalam masa 24 hingga 72 jam, kan, kita punya respiratory compensatory mechanism akan take over untuk normalizekan, cuba bantu normalizekan kita punya acid base balance. Kemudian ketiga adalah kita punya renal mechanism. Renal capacity mechanism ni apa yang Jenny dah terangkan tadi. That will take place after 72 hours. So after 72 hours, kita punya kidney will take action in order to generate new bicarb. Okay. So yang pertama tadi adalah dengan kita punya phosphate. So every molecule of phosphate will produce 1 molecule of bicarb. Right? So ini akan berlaku di mana, di alpha intercalated cells di distal convoluted tubule. Okay. Kalau untuk yang ammonogenesis pula, okay, ammonogenesis tu kan tadi Jenny ada cakap pasal this one specific enzymes yang convert glutamin tu, kan? So glutamin ni datang daripada mana? Sebenarnya glutamin ni datang daripada liver. Kan? So glutamin ni datang dari liver dekat dalam proses urea synthesis. Kan? So daripada urea synthesis daripada liver tu, kan, dia ada 2. Kalau kita tengok balik dalam urea cycle, kan, urea cycle akan terbagi kepada 2 lokasi. Satu di perihepatik dengan satu lagi di periportal. Perihepatik dengan periportal region, kan? Cara kita punya sinusoids. So glutamin akan dihasilkan daripada situ, kan? Dia akan bawa ke kita punya kidney, dan daripada kidney dia akan absorb dalam kita punya, first kali adalah dekat kita punya thick ascending, dekat kita punya proximal tubules, kan? Kemudian di proximal tubules yang akan berlaku yang pertama sekali dalam ke atas, kan? Dekat atas, dekat graf ke atas tu. So glutamin, kan, will be converted into glutamate by glutaminase. Kemudian glutamin ni will be converted into alpha ketoglutarate, dan akhirnya dia akan menjadi bicarb. Kan? So daripada glutamin, yang glutaminase ni akan pecahkan glutamate dan juga ammonia. Kan? So ammonia ni, it's highly soluble. Kenapa? Sebab dia ada lipid. So dia lipid soluble, so dia boleh transfer masuk ke mana-mana. Tapi ammonium, kalau kita tengok NH4+ tu, dia insoluble. Dia memerlukan transporter untuk masuk ke dalam lumen. Kan? Kalau kita tengok tu dekat dia punya tu, dia adalah sodium ammonium co-transporter, sodium ammonium antiporter. Sodium masuk dalam sel, kan? Ammonium keluar, kan? So this ammonium akan dibawa keluar sampai ke kencing kita, kan? So ammonium will be excreted, not ammonia, kan? So ammonia ni is freely diffusible, dan apa ammonia ni akan buat, dia akan pergi ke dalam kita punya medullary interstitium, dia akan stay ke dalam tu. So selepas di proximal tubus, dia akan pergi ke loop of Henle dekat tip ascending limb of loop of Henle, kan? So lepas tu ammonia ni akan diabsorb balik, kan, oleh ammonium ni akan boleh diabsorb balik. Bukan ammonium. Ammonium ni will be reabsorb masuk dalam kita punya tubules dan dalam kita punya medullary interstitium, kan, melalui kita punya sodium potassium 2 chloride channel, kan. Yang ini di mana furosemide akan act, kan, sodium potassium 2 chloride channel. So dia akan masuk balik. Okey, selepas tu bila sampai di alpha intercalated collecting duct ni, kan, so apa dia akan buat, kita punya macam apa saya cakap tadi, ammonia ni it's freely diffusible, so boleh diffuse daripada interstitium masuk ke dalam lumen, kan. Yang tu, kan. Selepas tu kalau kita tengok ni, kan, CO2 campur H2O, carbonic anhydrase, kan, convert into carbonic acid, kan, lepas tu dipecah balik kepada hidrogen dan juga bicarbonate. So that bicarbonate will be reabsorb masuk dalam blood untuk masuk dalam kita punya bicarb pool. Okay, so kalau kita tengok tadi, kan, yang macam ni, kan, yang ammonia tu, kan, yang daripada medullary interstitium, kan, so dia akan bicarb yang daripada carbonic anhydrase tu, kan, hidrogen daripada carbonic anhydrase tu, dia akan keluar daripada tubular cells masuk dalam lumen, kan, by way of sodium ATPase, and this sodium ATPase is influenced by aldosterone, kan. So bila ammonia masuk, kan, dia akan bind to hydrogen yang keluar daripada tubular cells by hydrogen ATPase, dan dia akan combine dan akan menjadi ammonium. So ammonium ni will be excreted out. It will not be reabsorbed back. Kenapa? Because of its charge, kan? Dan this phenomenon is called diffusion trapping. Maksudnya once dia dah daripada ammonia menjadi ammonium, it will not be reabsorbed back into the tubular cells and into the blood via basolateral membrane. Why? Because dia charge dah bertukar dah, dan dia tak boleh, dia dah trap lah dekat dalam lumen. So ammonium tu will be excreted out. Okay, so apa yang so gini, so contoh-contoh apakah clinical application yang kita boleh pakai berdasarkan daripada fisiologi ni?
Apa lagi, bos?
Clinical fisiologi, apa clinical application? Contohnya, okay, kalau dalam kes apa yang kita akan nampak macam ni? Contohnya kalau dalam urine pH rendah. So kalau misalnya kalau urine pH rendah, apa yang berlaku? Kalau urine pH tinggi, apa berlaku? Dalam keadaan acidosis, apa yang berlaku? Kalau misalnya kalau patient tu ada hyperkalemia ataupun hypokalemia, what will happen?
Kalau patient dia hypokalemia, your kidney will tend to replenish back the potassium which is depleted in your body. So you will activate the hydrogen potassium punya I forgot the actual name, but it's a hydrogen and potassium punya exchange lah. So he will tend to retain more potassium and excrete more hydrogen outside. So your urine punya hydrogen will be higher lah. That's why if in patient with hypokalemia, the urine punya pH tu akan rendah. It's more lower lah because of this mechanism. This is what my understanding lah.
So in hyperkalemia ataupun hypokalemia, kita cakap specifically about potassium. So in hyperkalemia, so it will actually inhibit ammoniogenesis. So in hyperkalemia, it will reduce the ability to excrete hydrogen as ammonium. Yeah? So this will cause type 4 renal tubular acidosis. So in hyperkalemia akan menyebabkan acidosis. Kenapa? Because kita punya bicarb generation tak boleh berlaku. Kan? Sebab dia akan inhibitkan ammonia-genesis. But in hypokalemia, kan, it will induce ammonia-genesis. Kan? So bila dia induce ammonia-genesis, so dia akan increasekan the amount of bicarb to be produced. So it will, so patient will not have acidosis. Kan? Sama dengan urine pH juga. If the urine pH is low in acidotic patients, kan, if the urine pH is low, so it will activate ammonia-genesis. Kan? So more bicarb will be generated, and urine pH and serum pH will increase. Okay. Any questions? Ada soalan daripada participants? I think this morning's topic agak dry because it's physiology, kan? Ada soalan sesiapa? Okay. Sepatutnya Syawal Syawal present berkenaan dengan intradialytic complication, tapi saya rasa saya tak dapat nak jumpa dia, kan? Tak dapat nak cari dia. Kemungkinan dia ada urusan yang lebih penting yang membuatkan dia tidak boleh hadir untuk memberikan presentation beliau. Mungkin kita akan postpone presentation beliau ke minggu hadapan, kan? Oleh itu kita di penghujung sesi kita pada hari ini, kan? Terima kasih kepada semua yang hadir pada hari ini. Diharap semua akan semua will have a good day today ahead, kan? And I'll see you guys soon. Okay, assalamualaikum dan terima kasih semua.
Thank you. Terima kasih Toma.
Okay,
terima kasih.
Thank you, Bash.
Okay, welcome.